about embedding weight management interventions in the NHS. I'm going to focus on two parts today, but I thought it would be helpful to understand where I've come from. So prior to my academic career, I worked in public health as a public health practitioner, and I was commissioning weight management services in the Southampton area for the NHS. I then moved on to local authority, working mainly in childhood obesity rather than adult weight management services. And after that, I really wanted to make sure that everything I did was evidence-based. So then I moved on to the University of Birmingham, and I completed a PhD in behavioural weight management interventions in primary care. So I've spent about 14 years so far working in weight management, which feels like a very long time now. But after my PhD was finished, I was lucky to go to the University of Sydney and again worked in weight management, more in secondary care rather than primary care. And then to come back to the UK, I worked at the University of Oxford, again around health behaviours, weight management, before coming here to Loughborough University in 2020. So lots of weight management experience, and also the public health implementation experience as well, which is, I think, is really important and one of the things that I like to do in my research. I always get asked a lot of questions because weight management is always very popular. And one of the questions is, what's the best way to help people manage their weight? And I'm hopefully going to answer that to you today. I also get the question, or maybe the statement, doesn't everyone put the weight back on? Well, sometimes, yes, that's true, but it's not as bad as we think. So I will share with you the evidence of why that's not the case. And finally, how much weight loss is beneficial for health? Shouldn't I be losing 2-3 stone? What is the benefit? And so we're going to look at that today as well. And the way I've structured this presentation is that some of my research is focused in primary care, so at your doctors, and then the new research that I'm getting quite excited about is in secondary care. So how do we embed weight management into secondary care? I like to start off with a patient story because sometimes we forget that weight management can be really, really hard. So this story is from interviews that colleagues at Oxford undertook, and then they put them on a website which is down there called Health Talk, which is great because it's got snippets of videos about people's experience, and it really does help you put it in context. So for example, Ria, she was relatively slim until her 40s. And then when she hit the menopause, she started gaining weight. She wanted to lose weight for her daughter's wedding and decided to go on a diet. But shortly after that, her son was killed in a motorbike accident. And that meant that she gained 3 stone because she was emotionally eating and comfort eating. And I've heard this story a number of times since I've been working with people with weight management, and there is more complex issues that you have to consider. So I do want to recognize that before we go on and think it's very easy. So first of all, a few terms. So obesity is normally measured using BMI, which is your body mass index, and that is your weight divided by your height squared. And yes, for a rugby player, that most probably isn't the most accurate measure, but at a public health level, it is what we generally use. And we know that if you're within the obesity category, then it is associated with health problems such as type 2 diabetes, cardiovascular disease, osteoarthritis, and some cancers. So it is important. The other terms that you might hear in this presentation are weight gain prevention. So this is preventing weight gain in the first place, which ideally we would do so that the benefits are greater. And then we focus on weight loss, which is self-explanatory, and then weight loss maintenance. So trying to maintain that weight loss. And there's some evidence to show that should be within 1 kilo of how much weight you lose, because otherwise you regain that. And finally, we say living with obesity when we refer to people who are living with obesity, because it's a nicer term and less stigmatizing. So overall, the population is getting heavier. This is most probably a bit out of date, but the dotted curves are between 1991 and 1993, and then the full curves are between 2011 and 2013. And you can see that the whole curve has shifted, and it's most probably likely gone further. Currently, there are about 60% of the population are classified as living with overweight or obesity, and so much less people in this healthy weight category. And one of the biggest things, and this came out last year, is that obesity could take over smoking as the preventable cause of cancer in women by 2035. So it's an area where we need to target, and we need to give people to help to manage their weight. So within England, we have an NHS care pathway for weight management, and we have a tiered service. So your first tier, your tier 1, is your universal intervention. So these are things like make sure you eat your fruit and vegetables, your 5 a day. We have the Start for Life campaign, which involves pregnancy and the first 5 years of life, where we try and encourage healthy eating, and that's for everyone. You've also got the sugar sweetened beverage tax, which would have come under a population level intervention, which has reduced the amount of sugar in fizzy drinks, and that has resulted in less consumption of sugar. So that's your tier 1, generic universal interventions, weight gain prevention, that everyone can receive. Moving up, the tier 2 lifestyle interventions are multi-component weight management services, normally including diet and physical activity, and lots of my research is focused on these tier 2 services. And then moving up the pathway, tier 3 services are multidisciplinary teams. So you've got the clinician, the dietitian, the psychologist, the exercise professional. And I have to say that tier 3 services vary throughout the UK, and the access to them also is very hard to figure out sometimes. Similar to tier 2 lifestyle interventions as well, which I'll go into in more detail. And finally, the tier 4 service is your bariatric surgery. So you have to go through all the services before going to tier 4. And normally tier 3 and tier 4 means that there's complex obesity. So for example, there's comorbidities such as type 2 diabetes and other health problems to get to that level. So tier 2 weight management services, they have to include diet and physical activity. They focus on behaviour change, and they're generally group-based. We don't get many individual services. And examples are commercial weight management programs, so things like Weight Watchers, Slimming World, Rosemary Connolly, or that was only online, I think now. Another option is football fans in training, which was specifically for men and linking in with the football clubs, which was a great program. And then there's other bespoke programs developed by the NHS. So in Leicester, we had the DEL program, which was specific for people with Asian ethnicities and focused on foods that were appropriate, or other providers. So for example, one of our partners is Gateway Family Services in Solihull, who provide bespoke weight management programs. So these are your tier 2, and this is where most of my research is focused on. So that question about the benefits of weight loss, well, this is a big study in the US called the Look Ahead study, and down here it's a bit blurred, but when you get to this fourth line is 5% of weight loss. So you've lost 5% of your body weight, and on this side of the curve is glucose. So you can see that as soon as you hit 5%, there's a definite decrease in blood glucose, which is what you have before you, is a measure of kind of nearly to get type 2 diabetes if it's too high. So if we can reduce that through weight loss, it is very beneficial. And again, this is fasting glucose. So we've got HbA1c and fasting glucose. But the thing to take from this graph is that there's linear benefit. So any weight loss is beneficial for health. And again, you can see it with blood pressure here in systolic and diastolic, and the change in triglycerides. So everything, more weight loss, more beneficial, but there is a linear relationship. I also want to share this slide because there are lots of new obesity drugs coming out in the market, and sometimes it's seen as an easy fix, but this drug, sibutramine, was a trial that was completed by my professor in Sydney, Ian Caterson, and he looked at sibutramine, which has since been withdrawn anyway. But if you look at sibutramine alone without any diet or physical activity, there's not much difference. And again, with sibutramine and brief therapy, but if you combine them, then there's such a big difference. So even if these weight loss drugs are available, and some of them are very appropriate and good, then you also need the diet and physical activity. So to bear that in mind. Right, how can we help in primary care? Well, we could just tell people you need to eat less, but we also forget about physical activity, which is the magic pill, which has independent benefits, even if it doesn't help you to lose weight. And people know that. They tend to know that they need to eat less, do more, but it's about how we can get people to do that and how do they enact that behavior. Now, primary care is very challenging. It was challenging before COVID. It's most probably more challenging now. We have GP lists, which have over 1,000 patients who may benefit from weight loss because of the high prevalence in the population. We have a quality outcome framework, which requires GPs to record BMI. So you might get asked to be weighed and get your height recorded, but it doesn't require them to offer treatment. So we can weigh people and tell them, oh, you're in this category, but they don't have to offer treatment. And sometimes it's very difficult to know what treatment is on offer because of the items get commissioned or decommissioned to the programs. And there's a perception that there's a lack of treatment options, that they don't work, people regain the weight. So it becomes very difficult. And that was before COVID, so now it's even worse. So the first thing that people sometimes struggle with is about raising the issue of weight. And these are two quotes. So Carol said that they weigh me, but then they changed the subject. And she thought they were a bit embarrassed to talk about it because she felt herself, she was big and she didn't want, and she said, but I was gearing up myself to be ready for them to ask me about my weight. And then there was Ellie, who didn't really know that the adverse effects of living with obesity. And she said, no one ever said to me, I've got to lose weight. And so maybe telling people or asking people to raise the issue of weight is really important. So how do we do that? Well, we have conversations about weight management. So first of all, we need to ask permission to discuss weight. So for example, you could ask, would it be okay if we discussed your weight? Are you concerned about your weight? Would you be interested? If people want to say no, we don't have to discuss it. You can ask them if you can discuss it at another time. Lots of people who go to the GP do say that, oh, I get told about my weight and my weight is causing every single condition, and it gets a bit too much for them. So asking permission is the first thing that we need to do. The second, these slides, by the way, I've taken from the Canadian obesity management, so the 5 A's, and I can send the link over. But they're a really good way to address living with obesity. So the second part is assessing for the obesity drivers, complications and barriers. So these are the causes of obesity, and they're massive. You can have, there's so many causes, going from your mental, with your depression, your eating disorders, mechanical, osteoarthritis, you can't move as much. There might be some other conditions, sleep apnea, and then your metabolic, if you've got type 2 diabetes. There's also medicines as well, some of the medicines that will cause weight gain, like steroids and things like that. And then the monetary side of things. Can they afford to access weight management? What does it mean? Can they continue changing that behavior? I had one patient who was told to lose weight. She's has cardiovascular disease and needs a quadruple bypass. And they said, oh, we need to eat healthier. But she's on some benefits. She works part-time, but has a very low income. and it increased her shopping bill by double. So how does she implement that? So assessing the drivers, the complications and the barriers is the next thing. Thirdly, advise. So advise on the obesity risk. Explain that there's more like benefits of modest weight loss. So 5% is a good target to start with, and that there is a long-term strategy. And if someone fails for one day, it doesn't matter, you can restart again. And then also discuss what treatment options they would be involved or they would be willing to receive. And then next, you would agree on realistic weight loss expectations and on a SMART plan, so specific, measurable, achievable, realistic, and time-based plan to achieve those behavioural goals. And that's coming at it together. And then in any ways you can assist in addressing the drivers and barriers. So whether it will be referral to a program or arranging follow-up. Some of the people who got interviewed for asking them about their weight management experiences said that I got sent to the practice nurse and was seen on a monthly basis, and that just helped me get started. So my colleagues did this really big trial that looked at embedding weight management conversations, so within primary care. So people attended a normal GP appointment. They didn't know anything about this study. We weighed them. If they had an elevated BMI, we consented them and didn't tell them that this was a study about weight management, just that we were asking them to weigh them and give the details to their GP. So then the GP gave a 30-second brief opportunistic intervention saying, one of the best ways to lose weight would be to attend a weight loss program. Would you be willing to attend? And 40% attended the weight management program they were referred to, which was great because most people weren't coming in to talk about their weight. They also lost 2.4 kilos of weight compared to 1 kilo in the control group. So yes, it seems a small weight, but only 40% attended a weight management program. So that was impressive. And then the good thing was that 25% lost 5% of the body weight over 12 months, which was amazing because that's one of the clinical benefits where we see. And patients agreed that it was appropriate and helpful for their doctor to discuss their weight. So this was a big trial that showed that giving people an opportunistic intervention to discuss their weight and offer them referral, and you had to book the referral for the patients, then that was helpful to them to manage their weight. However, their team have done some research since then, and if you don't book them into a weight management program, not as many attend. So you need that system in place. So we did a systematic review and meta-analysis, which just means you combine all the studies together to look at what could be done in primary care. So because of COVID-19, and Boris, when he got COVID, realized he had an unhealthy weight and wanted to lose weight, and thought that's one of the main risk factors for COVID-19 escalation, that we need to help people to manage their weight. So commissioned and gave lots of money for weight management services. And so we thought, well, we know that referral to a weight management program works, but what can people receive in primary care if they go to their GP, and what would be helpful? Because not all people want to go to be referred to a weight management program, such as a commercial program. There are less men involved. And so we needed to look at primary care. So we looked at adults, and the intervention was a behavioural weight management program. It had to be delivered in primary care, so you couldn't refer people to a program. And the comparator, so how we compared the two groups, was the usual care, an attention control, which just means they got the same number of sessions but nothing to do with weight management, or a waitlist control is where they get the weight loss program afterwards. And the outcomes were weight change at 12 months. So we had 27 studies throughout the world with data from 8,000 people. Some programs only have one short advice session with a doctor, while others involve multiple visits with their GP or a dietitian or a health coach or a nurse. And the length of the programs varied from 3 months to 3 years. So even though there was one short advice session, they were then asked to follow the program for 3 months. And most of the programs were in person with very few online over the phone. But I think that most probably has since changed because there are many more programs online. And they were delivered by health coaches, GPs, nurses, dietitians, and a mix of those combinations. So this is a forest plot from our systematic review, which just means that it pulls all the data together. So for example, this first one, Apple, the intervention group lost minus 5.4 kilos here, and the comparator lost minus 1.1. We normally expect the comparator to lose around 1 kilo because they've decided to take part in the trial, and although they're not offering support, being watched by someone tends to make them lose weight. So that's why we look at the mean difference, which is this final column of minus 4.3. And so this forest plot pulls it all together into this lovely diamond, which then says whether it's successful. And there was a 2.3 kilo difference. So that's between the comparator and the intervention. So that meant that the intervention group at 12 months lost minus 3.7 kilos and the comparator lost 1.4 kilos on average. So a 2.3 kilo difference, which again, some people will say is quite small, but it is cost effective of having those programs. And I'll show you why it doesn't result in too much weight regain. We also want to know whether there are any factors that affected weight over those 12 months. And we found that participants who had greater than 12 contacts during interventions lost significantly more weight than fewer contacts. So perhaps sessions need 12 contacts, and that wasn't weeks, it was just the number of contacts. We also explored who delivered the programs, and the health coaches did just as well as GPs and nurses. So perhaps health coaches can deliver weight management programs as GPs and nurses are very busy, and it might overcome the implementation. And the question I get asked is, what programs had the most weight loss then? Well, there were the two that were very different. So Lean is minus 9 kilos and Tahiri is minus 8 kilos. And this is because they included very low calorie diets. So very low calorie diets is one way to help people manage their weight, and it involves around 900 kilocalories per day from soups or shakes. It's total diet replacement, and you do it for up to 12 weeks. And then there should be support for 12 months for reintroduction of foods and maintenance. And it's mainly for people with type 2 diabetes. So we do have services in England that offer these very low calorie diets, but they were piloted in certain areas. And so they do work, and mainly for people with type 2 diabetes, but there was also a study in Oxford called Droplet that looked at it in the general population, and it does help people lose weight. And for diabetes, with the direct study, there was a 46% remission rate. So people were classified as not having type 2 diabetes. And the weight loss is large, 10 kilos at 1 year. Right, so does everyone put the weight back on? Well, this video is very nice, and I'm not going to show it to you today because we're going to run out of time, but the gentleman talks about how when the light is switched on, he's able to manage his weight. He can carry on with changing his behaviour, eating it, or for a short period of time. But when that light switches off, it's really difficult. And so that people do tend to regain the weight over the time, and this is by net change in BMI. This is at program end, and this is the follow-up after the program. So you can see that the curves generally tend to have an increase. But that saying, a colleague from Oxford had a great big systematic review, so pulled all the studies together, of 155 trials. There was greater than 150,000 people in those trials, so it was a lot of work. And they looked at the weight regain after program end, and it was only 0.1 to 0.3 kilos per year greater in the intervention compared to the comparator group. So the intervention, although they lost more weight initially, they did regain weight quicker than the control group. But there was still significant differences between the two groups at 5 years. So they were at a lower weight during that time. And they also found that the initial weight loss and subsequent regain would be cost effective if interventions were delivered for under £560 per person. And most of the programs tend to be this. The very low calorie diets might be a little bit more. So yes, people can regain weight, but it's not as bad as we think. And I think having an initial weight loss is much more beneficial than having no weight loss whatsoever, considering there's benefits for health. And we still need to do some work on this area. So hopefully we'll get some funding later on in the year where we can explore weight loss maintenance. I've also put some training here if you were interested in more. So there's healthy weight coach training, if anybody's interested. There's a step-by-step guides for how to talk about weight with a nice video here for 7 minutes long. And then these are the NHS digital weight management programs that are available in the UK. Because one of the main things is that I think GPs and people who refer people to services find it hard to know what is available in their area. So moving on, secondary care is where I'm going to next. And this was because of my dad. So my dad is here on the left with my two boys trying to play football, and he was waiting for a hip replacement, and he was told to lose weight, but he wasn't offered any support to do so. And so I thought, why are we not offering weight management for people who are having hip and knee replacements? What's going on? He was in a manual job, he was a double glazer, so it's wear and tear on the body. He's gained weight over the time and just needs to lose some weight, but he wouldn't necessarily go to a commercial weight management program. But he did lose weight before his hip replacement, and it did help him. But now we've got to work on the knee. So this is where secondary care has come from. And another patient story here. So Myra's story was that she had to have surgery for a hernia. And she said, her doctor said, you need to lose 4 stone. And she joined Slim & World and did it. And she just liked having that goal of an operation. So it feels like surgery, because there's surgery coming up, people have a goal to work for. And it's a teachable moment where people are going to be more motivated. And especially if they know that the benefits for their surgery and reduce their risks, then it could be really important. So she was able to stick to that diet because there was a specific time period she could do it in. So why is living with obesity bad for surgery? Well, there's the anesthetic risk, getting the tube in, the amount of drugs that's needed. There are many risk factors. There's also longer operating time, so it's more complicated operations for the surgeon, which means greater anesthetic. And then in some cases, specialist equipment is needed. There's longer recovery for things like wound healing. If there's more fat, then the wound doesn't heal as well. There's urinary tract infections. And then there's worse outcomes for the patient. So less recovery or more longer stay in hospital, more infections. So it's really important that we consider this, and especially as we've got long waiting lists, it might be an area where we can tackle. And I'm hoping to do that. I've put some funding in. I'm hoping by the end of the year, I'll know whether I've got that and we can work at doing this. One of the other projects I've worked on is that actually obesity increases inequality. So this is data from the Northeast North Cumbria area. And this is the number on the waiting list with who are waiting for elective, low risk or high volume surgeries. And so you can see lots of people on the waiting list, but on the left is the most deprived quintile. So people in the most deprived quintile, which means areas of deprivation based on the index of multiple deprivation. And you can see obesity is higher, nearly 6%, 7% higher. Again, BMI is higher. All of these are significant. They've got type 2 diabetes. So there's many more inequalities in those from the most deprived area, which limits the access to new treatment hubs, because you can't go to these new treatment hubs if you are a high risk factor, because they don't have access to the emergency services that are maybe as needed. You also can't go to private hospitals where some of the waiting list goes, so it's limited by BMI. So actually the inequalities increase even more because you're on the waiting list for longer. So I want to look at weight loss before surgery to reduce those inequalities. And this systematic review came out, I think, 2021, but there were only 3 trials and they all used very low calorie diets. And my dad would definitely not be interested in doing a very low calorie diet. He's happy to try and lose weight and do it in small ways, but he wouldn't be interested in doing this. So we need to look at other ways too. And what we don't know is if weight loss directly before surgery is beneficial. So one of my mentors, Professor Gavin Murphy at Leicester, he has got 2 trials running at the moment, which is looking at weight loss before cardiac surgery and also trying to get people to gain weight, because he's found that those people with a BMI of 30 is protective of cardiovascular surgery. And that's with observational evidence. So we don't know whether it's true, but we have to be careful. So we also need to know, is it actually beneficial before we do it? And we don't know whether it would be beneficial across all surgery types. So hip and knee surgery have long waiting lists. It most probably is helpful to lose weight before. It would help afterwards as well and prevent a range of chronic diseases, but we need to check whether it does. And also for types of cancer, when you're going through chemotherapy, I've got a colleague in Oxford who's going to look at this, and that's really important research that's going to come out. So that's a whistle-stop tour of everything, but there are some additional research that we're doing with Incline. We've got weight management for people with spinal cord injury. Jess, one of our PhD students who's a dentist as well, is embedding weight management in dental settings. Our other PhD student is looking at the small change approach for weight management, and next steps are to work out where we can embed that with NHS. And then we've got weight management before orthopedic surgery. So if you're interested in some of our other research, please check out our website, which is just down here. And then to summarize, weight loss of greater than 5% is beneficial for health. It's about choosing a program that you can stick to. So a variety is always good to offer to people to find one that works for them. Relapses happen, but try again the next day. And we do have successful interventions that we can refer to, and it's just about embedding them. So I think my call to action would be that we have a range of different services, but we have a central hub where doctors, GPs, people refer to can go to, and then we sign up the patient to that service. Because without that central hub, you don't know which services are available in your area. Even myself, who's worked in the public health area, I'm trying to find services. I'm like, which one is it not? Has it been decommissioned? That most probably links in with funding. So these might be blue sky thinking, but this is what I would like. I think we should ask patients if we would mind talking about their weight, advise, refer them for help. And we know that health coaches can deliver interventions, and we should offer weight loss while we're waiting for elective surgery. And there is some services that are starting to do this. So yeah, thank you to my collaborators. I've most probably missed some, but these are some of the people I'm working with at the moment who are helping me develop my ideas and my research. And if anyone is interested, if you're a patient, a member of the public that are interested in weight management, we would love to hear from you. And you can advise us about the research and what we should be doing. So we're grateful for any time. So do get in contact with myself. And then questions.